that helps us understand kind of the next set of questions that we have with our patients.
Right.
And Tom, to you, what do you talk to your patients about goals of therapy, how you've chosen their characteristics? You know, we're always talking about personalized treatment for cancer these days. So what's that conversation like, and how do you think about it?
Yeah, thanks, Bob, for that question. I think it's probably the most important discussion that we as medical oncologists have with our patients, and that usually it occurs during that first encounter, that first consultation. And oftentimes as a medical oncologist, at least in my practice, I'm sure it's represented in everyone here, that we're the first ones that actually have that emotional-filled conversation with patients where we're actually talking about their mortality. So in that conversation is natural goals of therapy and laying out to the patient that our metastatic kidney cancer, although we've made a lot of advances over the past several years, and many of these advances they may be aware of because they're in the news and in the press, that it's still not a curable cancer. But despite that, we have new therapies that can allow them to have a meaningful extension in their life with hopefully maintain quality of life. So I'm stressing with them, these are the goals that we can accomplish with the current plethora of drugs that we have available to us, and then allowing the patient to respond to me with what their goals of therapy are. And this is where you get that individualized approach. It may be a patient you see that has children they want to get to graduation, or they have a marriage, and you can start tailoring your choice of therapies superficially with that discussion. And then the next step going down is actually more to the science and what the clinical trials tell us. Is there patient populations from the group of drugs that seem to benefit with one therapy over other? Is there particular disease comorbidities that would lend itself to choosing one agent over the others? And we're all sophisticated enough at this table, and I think many of our medical oncology colleagues out there are too, where we're able to dissect the data out, and we know that certain classes of drugs that we have, the VEGF inhibitor class, for instance, are going to have their set of toxicities, and therefore, you know, for instance, cardiovascular toxicities there. If we have a patient that has comorbidities that are along that line, may give us pause and have us choose one or the other. Another class, for instance, would be mTOR inhibitors, which have their own unique toxicities, for instance, diabetes issues and things for the patients with brittle diabetes. So I think there are ways with the drugs that we have to kind of individualize the choice of therapy based upon patient characteristics. The tumor characteristics we alluded to already, that the pace, the rapidity, and how fast the cancer is growing may allow you to choose one agent or another. But as we all know, we have a standard kind of protocol that we follow, a paradigm. A lot of us will use NCCN guidelines, et cetera, that list out agents. There have been drugs that have been approved in particular settings. So, you know, if we're starting off with initial therapy and we make the decision we're not going to wait in this patient, I think that's important, as we've discussed, to consider. But if we need to start systemic therapy, then we know that we've got clinical trial options for our patients, and then we've got commercially available drugs, and we've got, generally right now, most of us would think of two drugs. They're both VEGF inhibitors, Sutent and Votrient, as being options to choose from, and that's how it goes.
So David, most of us are old enough to remember when most of the endpoints for clinical trials were PFS and response rates. And we're entering an era where we now have approved drugs, cabozantinib, nivolumab, where there's clear and pivotal evidence to demonstrate survival enhancement. How do you think that fits into the discussion of goals of therapy currently as compared to where we were a decade ago when it was not as robust a data set?
Well, I think it's exciting to be able to tell patients, in some cases for the first time, that we have drugs that improve overall survival. That's a endpoint that means something even to the layperson. These drugs are going to help you live longer. Explaining progression-free survival to the average patient is, you know, it's not an easy discussion to have. So to be able to say for the first time that we not just have one, but we have two drugs that can lengthen your life in a meaningful way is great. I think being able, with further follow-up from both studies, we may be able to give them a sense of how likely they are to be alive at certain points, you know, 2 years, 3 years, 4 years. For both studies, we don't have that information yet, but it's a sign of the impact of some of these treatments. I mean, the improvements in overall survival, both with cabozantinib and nivolumab, are not just statistically significant, they are clinically meaningful. Patients are living much longer. And like, for example, in the nivolumab phase 3 trial, as you know, the overall survival for the patients getting nivolumab, the median was 25 months. That is as good in the second line as we were seeing in the front line. And that's not just a nivolumab story, but that's a story about all the subsequent drugs that are active. So our patients are living, I think, 2 or 3 times longer than they were 5 or 10 years ago, and they're coming back to clinic. And, you know, it's a much different environment to treat patients with kidney cancer these days. You actually have to consider long-term issues where that wasn't the case 5 or 10 years ago.
And that really does raise the topic that Tom spoke to, which is even though some of those results are in the second line setting, they do impact our conversations with our patients in the newly diagnosed patient.